Good afternoon, everyone. This is third grand round from the Department of Rheumatology, so I welcome you all to this. As usual, the attendance is so sparse, but I think even fewer they can make a lot of difference. From our department, Dr. Rudhu Goswami will take the lead for this grand round, and the faculty from the department they will present the AIIMS experience. Having said that, we are presenting the grand round of scleroderma. So many of you will be knowing what scleroderma is. During, I remember late 90s when we used to see cases here at AIIMS, they either welcome you, sir. So it's good. We are fortunate that we have our DE now in this grand round we were talking about. Thank you so much. So we used to have cases where they had auto amputation or surgical amputation of their lizards. We did not have treatment for Raynaud's phenomenon. Even the PAH and ILD, there were diagnostic issues. Treatment modalities were not available. Now we have lots of options available. So I think it's the right time where we review the systemic sclerosis or scleroderma in details too. I'll invite Dr. to take over.
Thank you, madam, and thank you, the audience, for coming. Good afternoon. Let's start with our discussion today. So, this is in all our basic structure. So, as you all know, scleroderma is a disease not confined to skin, also involving almost the entirety of the systemic architectural environment of the body. It's a rare disease, and the three basic pillars of scleroderma are vascular involvement, fibrosis, and autoimmunity. This is our own long-term follow-up cohort of approximately 360 patients with a median follow-up duration of 6 years. The male to female ratio is highly skewed towards the females. Majority of our patients, 3/4 of our patients were diffuse cutaneous and 1/4 were limited cutaneous. Majority of the manifestations involved cutaneous manifestation in the form of Raynaud's phenomenon. Almost all of the patients of scleroderma will have at some point of their time like a Raynaud's phenomenon. Almost half will have a digital ulcer, and almost 1/6 will have at least one ganglion. So how do you manage it? This is one of the earliest experience of treating cutaneous manifestation, that is impending ganglion and severe Raynaud's, with phosphodiesterase 5 inhibitor. And this was at the time when phosphodiesterase 5 was still yet to come in our guidelines. We had shown, my predecessors had shown that phosphodiesterase 5 inhibitor sildenafil had an excellent cutaneous response in the term of more than 40% complete healing, and the others had at least a partial response. Regarding internal organ involvement, the major chunk is taken by pulmonary and cardiovascular. The other involvements, though not major by their number, but significant by the affection of the quality of life of our patients, are GI manifestations, musculoskeletal manifestations, and significant cutaneous manifestations like calcium, which is remarkably difficult. So if I take a patient and review her journey over the years, the journey will possibly start with an insignificant Raynaud. It will go over years with progressive skin changes, progressive loss of tissues over the distal parts, and progressive involvement of one after another internal. So what can we do to prevent it? The obvious thing is to diagnose early and to treat with effective management as early as possible. This is the 1980 criteria. If we use this criteria, the patient has already developed full-blown scleroderma. This is the 2013 criteria. If you use this, our delay in diagnosis is significantly reduced. Have we achieved that? I will show you that we have achieved that. So our outcome measures, in rheumatology, we like to talk in terms of outcome measures. Our outcome measures go in three pillars: cutaneous imaging, vascular imaging, and optical. So this is a very nice cartoon showing vascular imaging. This is infrared therapy. And at the current time, if you are willing to spend 20,000 on an infrared camera, and if you have an iPhone, you can do it at the patient site. It takes maybe 5 seconds, and you can ask the patient to sit in the AC for 45 seconds, come out of the testing, expose the hand to maybe a gloves, and retake that image, and it can beautifully show a normal hand is significantly different from a sclerotic hand. In rheumatology, we always like to talk about musculoskeletal with very high frequency probes, linear probes of more than 50 megahertz. This is a 70 megahertz probe. Almost a histology level radiology pictures can be obtained. They are good. They have a good, change over time, but their reproducibility is also good, but availability is an issue. So this is our data over the past 3 decades showing reduction in delay in diagnosis. Look, we were almost taking 10 years to diagnose sclerosis. We have reduced that to less than 8. How have we done it? Mostly because of the excellent collaborative work that we have. Because we have great people who keep diagnostic thresholds low, which keep reference to us, and also due to the awareness work done by our predecessors over and over the past decades that we have achieved this. And at the very end, I would like to say that another muscular imaging in terms of nail point also accelerates in early to deliberate on that. I would like to call Dr. Bhav to discuss this.
Thank you, Dr. Rudra. As you know, that scleroderma is a disease of microangiopathy where the pathology lies in the terminal vessel, which is capillaries. So how do we examine that? We can examine by doing this video capillaroscopy at the nail fold. Nail fold is the place where the capillaries lies in the horizontal form. Otherwise, in the other organs, it is the vertical form. So it looks like this is the video capillaroscope, which is in our department, which consists of various type of lenses, 100x, 200x, 300x, and cold light, which another is adapter, which can adjust that accordingly, and video printer. We have the inbuilt software which measures all these parameters in the capillaries. So prerequisites for nail fold video capillaroscopy is acclimatization of the patient. We have to acclimatize the patient in the constant temperature for 15 minutes so that the vasoconstriction goes away. Otherwise, it will give false positivity of the avascularity. And transparency of epidermis has to be determined because there should not be any dirt, there should not be nail polish, and mainly should not be applied on the examined area. What are the image acquisition? We are acquiring image on all these 8 fingers. These can be divided in each finger can be divided in the 4 parts. So 32 images has to be taken, and all these images can be taken as an average. This is the 50x, 100x, and 200x. It appears in this way. We have to look at the terminal part. This is the distal most part of the layer, where these are appearing as a safety pin appearance. There is afferent different capillaries. So normal parameters are the capillary density. In the 1 mm area, the capillary density lies between 9 to 13, and average is 9, usually placed parallelly without any changes, and any alteration in the these can be considered as a early changes. Capillary diameter is afferent and efferent is different. Afferent is little less than the afferent. So afferent is 6 to 19 micrometer and afferent is 8 to 20 micrometer. Semi-quantitative method to evaluate all these parameters is look at score is 0 means there is no alteration, absolutely normal. Score 1 less than 1/3, 2 is 1/3 to 2/3, and more than 2/3 is score 3. So this is how, when we are acquiring 2 images, we have to take the mean of these 2 images, looking at the giant capillaries, micro images, ramification or disorganization. So again, look at these. If you are acquiring more images, we have to take the mean of all these images. Okay. So looking at these parameters, this is dilated capillary. Here we can see the diameter of this capillary, which should be less than 20. If it is more than 30, it is dilated. 30 to 50 is dilated capillary. More than 50 micrometer is giant capillary. And the loop diameter, this is hair to hair. If it is more than 100 micrometer, it is giant capillary. Then coming at this is early phase. Then this going the active phase where there is active hemorrhages. Active hemorrhages is nothing but the disintegration of the giant capillaries. Then followed by this disorganized capillaries, ramification. All these are late phases where we can see all these changes. So in the scleroderma, we are looking at the early, the active phase and the late phases. Early means, as I have discussed, when there is giant capillaries, a few giant capillaries, that is active phase. More means more frequent giant capillaries and frequent hemorrhages, that is active phases. Even the neuroangiogenesis happens with the preserved capillaries. Late phases means there is absence of capillaries, that is avascularization or the desertation of the capillary formation. If the reduction in the capillary number in the 1 mm area, that is considered a late phase of nail fold video capillaroscope. This is early phase where you can see dilated capillary as well as few hemorrhages. Late active phase where the more giant capillaries and more hemorrhages. Okay. Late phase where there is no giant capillary, no hemorrhages, only the disorganized capillaries are seen along with the lack of means area where there is vascularization. So what are the, if you are acquiring all these images, what can be the mistake while you are acquiring all these images? You can exert more pressure while putting the lens so that it cannot give you the proper images. The blood flow is obstructed by pressure, so that it gives rise to like absence of capillaries in that area. So you have to apply the minimum pressure in the examined area. There can be some microtrauma. He is the guitar player where there is microtrauma, which having the hemorrhages. It can be wrongly diagnosed as a scleroderma pattern. If you are applying more oil or less oil, it will give the artifacts. So with that, I would like to hand over this presentation to Dr. Rudra again. Thank you.
Thank you, sir. So we are coming to the third and interesting pillar of diagnosis of scleroderma, that is autoantibodies. Let's review some of the patterns. This is the classical SCL70 pattern. This is the centromere pattern, and this is the PST0 nucleolar pattern. This is the PMSCL nucleolar pattern. This is a very beautiful picture of a Joe1. I'm showcasing this just to highlight that when we have these patterns in our indirect immunosources, we don't really need an LI to confirm. They're so specific. So this is just a representative image of our immunoblot. So among our cohort, majority of our patients had only a single autoantibody, but up to 5 autoantibodies could be present. So the natural next step, we did a cluster analysis of our autoantibodies. And we identified 3 different clusters. The first one was SCL70 plus RNA-ball PMSCL group. The second was one SCL70 plus Rho group. And the third one was centromere H group. Do they have any clinical significance? Yes, they do. While the vascular, the cutaneous manifestations were equally distributed among these autoantibody clusters, interstitial lung disease was enriched in the autoantibody cluster 1, whereas pulmonary hypertension, calcinosis, and myositis were enriched predominantly in cluster 3, that is the centromere cluster, and somewhat in the SCL70 and Rho cluster. With that in mind, and the idea that majority of our clinical manifestation tends towards interstitial lung disease, let's take our clinical journey of interstitial lung disease of a patient with scleroderma. Let's start the discussion with Dr. Anish Shah from it.
Right. Thank you very much, Rudra, and thank you to the Rheumatology department for having me. So, interstitial lung diseases, as such, is far less common than obstructive airway diseases in our practice. But out of all those cases of interstitial lung disease that we see, CTD is one of the most important causes. So this actually outlines the most important cause of CTD. If you see the global data, which includes a lot of countries, including that of India, the orange bar indicates the bulk of due to CTD ILD, and we can see that it's a substantial number. Coming to individual CTD, you can see systemic sclerosis is right in the middle. So around 65% of patients of systemic sclerosis at any given point of time would be having involvement, mostly interstitial lung disease, which is actually the most common lung manifestation of systemic sclerosis, PH or pulmonary hypertension being a distant second. Now, just to drive home the point, I mean, the pattern that is seen, limited cutaneous and diffuse cutaneous. So in limited cutaneous, pulmonary arterial hypertension is more common. And the other, the other way is true for diffuse cutaneous systemic sclerosis, where lung fibrosis is more common. But these are not the only manifestations that we get to see. If you look at the pulmonary manifestations, they can be classified into direct, indirect, a combination. So apart from the common ones, you can have other manifestations like pleural effusion, drug-associated pneumonitis, or even airway diseases. So these are again not common manifestations, and most of these disorders, they have to be individually investigated according to their merit, because as you can see, a number of reasons can be responsible for these. Talking about ILD, so there are risk factors which pertain early ILD, and there are some protective factors. They are enumerated here. Most important would be diffuse cutaneous, limited cutaneous, higher skin score for higher risk factor, CPK levels, and cardiac involvement. So most of the patients of scleroderma lung disease that come to us already have a diagnosis of scleroderma, so they already have these. So the diagnosis becomes easier for us. As far as symptoms related to respiratory system is concerned, the most common symptoms are dyspnea and dry cough. And within signs, what we look for is a clubbing, a cyanosis, a Velcro crackles, which if found can be pretty specific for interstitial lung disease, as also a loud second heart sound due to pulmonary hypertension. Now, these are the tests that is commonly done, say, in a medicine OPD or a respiratory clinic OPD, pulmonary function test, which includes a spirometry, lung volume, DLCO, and 6-minute walk test, and imaging, and sometimes a 2D echo Doppler and right heart catheterization. So this is just a cartoon showing the relative utility of the individual tests at the different time points, initial, follow-up, prognosis, treatment. Probably you would be surprised to see that certain investigations like X-ray, which are commonly used, they are not really helpful. Red means not that helpful at any time juncture. Something like PFT, which probably is less commonly used, it is useful at most of the time points during a patient's disease. As far as pulmonary function test is concerned, there are some caveats which needs to be remembered. Saturation may be falsely, not recordable or low. There might be some false negatives. PFT has got its limitations. Around 2/3 of patients of who are having normal FVC may have an ILD proven on CT scan, and some measures like DLCO, they may be non-specific because they may be positive in a number of conditions, not only in ILD. One other beauty of pulmonary function test is that we can put a number, an objective, parameter to the patient's disease. We can quantify it depending on a TLC, FVC, DLCO. And now what has happened is we have moved to Z-score, which takes into consideration the normative data, and we can classify into mild, moderate, and severe based on the Z-score, which is provided in the PFT as such. The next common modality is CT scan. So my next speaker is going to talk about it, but it's important for a physician or anybody treating scleroderma to understand that, what are the basic features of interstitial lung disease, and the commonest pattern that we get to see in systemic sclerosis is actually the commonest pattern that we get to see in most other connective tissue diseases, that is NSIP. Thankfully, bronchoscopy, bowel biopsy is not that commonly employed in scleroderma because, again, most of the time the diagnosis is apparent. Sometimes we need bowel, especially when we want to rule out infections in patients receiving, say, immunosuppressants. Screening for ILD, these are the tests which are not helpful. Chest radiography, 6-minute walk test, bronchoscopy, not helpful for screening or even for monitoring. What is helpful? There are two views. One is the, the American view. The other is the European view. So this is what the ACR says, that they don't believe in doing CT scan in all the patients. They do believe in, first risk stratifying, increased risk factor, you do a pulmonary function test and HRCT, you diagnose ILD. If it is diagnosed, you treat it and then you follow it up after 3 to 6 months, PFT, or less frequently for CT scans. If not, then you move to another algorithm. I'll be talking about that. The Europeans, obviously, they differ with the Americans most of the time. So here also, what they feel is that a CT scan should be done for all patients. Why? Because most of the European studies show that if they follow this, they are missing a lot of patients who are having scleroderma ILD. Our protocol, what we follow, our policy is also to have a low threshold for doing HRCT in patients with scleroderma. Now, what are the prognostic markers? Both PH-ILD, they are bad prognostic markers. Any kind of lung fibrosis, any kind of decrease in FVC in dose-dependent manner, they actually portend a bad prognosis for the patient. And you can see, the Kaplan-Meier's for those having progressive versus stable and those having any lung fibrosis versus no lung fibrosis, they indicate again that the survival is worse off in these patients who are having these conditions. A few words about pulmonary hypertension. It's the second most common manifestation. 10 to 15% have pulmonary hypertension. It is actually, one of the leading cause of death. These are the risk factors: clinical, PFT, and lab. You can see it. It is interesting to note that the pulmonary hypertension in scleroderma, they can be of any of the 4 types, 4 groups as we call it. It can be group 1 commonly, but also group 2, group 3, and group 4, which are due to these conditions which are mentioned here. So early identification of pulmonary hypertension is important because if we install early treatment, it can make a difference to the natural history of the disease. However, there's a controversy regarding the best approach. What we follow and what is commonly prescribed by the guidelines is that we first of all look for symptoms of PH. If it is there, 2D echo, it's easy. If it's not, we look at risk factors, long duration, say more than 5 years, limited cutaneous, we do a 2D echo. If not, we do a PFT, and we look for some abnormality, which is typically in pulmonary hypertension, normal FVC and decreased DNCO. In that case, also we would do a 2D echo. If not, we follow the patients up, say after every 3 to 6 months, high risk for PH, usually 6 months. If there are new onset of PH, new onset of symptoms of PH or decreased DNCO, then we do a 2D echo. The follow-up tests, again, are kind of intuitive, and this is where the European and the American guidelines, they kind of converge. They believe in following up the patients clinically, PFT-wise, HRCT, and lab testing, most of which are done every 3 to 6 months according to the physician's discretion. But what is important is that we continue monitoring for ILD and pulmonary hypertension in all these patients because they can very well develop, not initially, but also during the course of the disease. So with this, I would like to request Dr. Sanjan to.
Good evening, everyone. I'm discussing the radiology. So we know that CT is the imaging modality of choice for assessment of patient. The scleroderma patient is affected by having ILD. CT not only helps in confirming the presence of the disease, but also helps us in telling the pattern of distribution besides the severity or extent. It also tells us exactly what part of the lung is having the active component and distributed, or in more case, to look for assessment medical treatment. It can also tell us about complications like superimposed infection or lung cancer, because these patients are predisposed. So this slide is mainly for the residents actually. If you had to fill the form for patients suspected of having pulmonary involvement in scleroderma, which CT would you advise? What about NCT? Not NCT, and why? So that is what I want to actually focus because this is common misconception that these are 2 different things. Earlier, traditionally, we used to acquire it in a different way. So they were different, but now that we have very machines very detectors, they are basically practically the same. If you write NCT or acquisition will be the same. The reconstructions that we the rate data. That is different. So we use this volumetric acquisition of the test, and then we reduce the expense. So what is more important is you need to know when you should write a contrast in study or not. So you write for contrast only if it is affecting a superimposed infection, or you think that some axis is otherwise contrast is not needed because you just need to see the axis. So coming to the radiological findings, this is an axial and corneal lung window image. We can see that there are lower lobe and peripheral distribution of the disease. We can see these cystic this were okay. We see these small cystic pieces with rounding reticular pixely, and there's definite subpleural scaling as well. And you can see some amount of video along with the GGO fibrosis. This is the example of NSIP because NSIP is the most common pattern. This slide is to show the importance of a Crohn's scanning because many times we do come across these dependent densities. So on Crohn's scanning, this should actually disappear. It's just dependent density, but if it persists, that it means it is significant and it's suggestive of an IID. This is another example of the NSID pattern of involvement with fibrotic changes along with a lot of GBO this time. Although the subpleural scaling is not very conspicuous, we can see that there are some areas that show the subpleural scaling. So the second most common pattern that is seen in scleroderma is UIP. So this is an example of a UIP patient with obvious honeycombing. We can see again in the peripheral distribution and the load. And on the corner, we can see the exact demarcation of the fibrotic part from the normal paving line. This to show that the second most common manifestation of pulmonary arterial hypertension, which is seen as increased diameter of the pulmonary artery compared to that of the this ratio should not be more than 1. We can also see that there is atrial as well as ventricular dilatation.
Good afternoon. So I'll be talking about the management of scleroderma ILD. So this is just our data of our ILD clinic that we have almost 20% of all ILDs are CTD, and out of those almost half are scleroderma ILD. So that means we actually have a very high burden of scleroderma ILD and scleroderma in rheumatology, dermatology as well as pulmonology. So when we talk about the treatment of scleroderma ILD, we need to answer these 3 questions. When do we decide to treat a disease? What are the drugs available and how do we choose those drugs? And how do we monitor these patients? So treatment decision in scleroderma ILD is not very straightforward. I would say the treatment would depend upon ILD severity. That means whether the disease is limited or extensive. Then disease trajectory. That means whether disease has been stable, progressively worsening, or it has improved spontaneously, or with the treatment for skin disease. Then we have to take into account the patient factors. Age of the patient, that means whether patient will be able to tolerate the drugs, expected adverse effects. Supposedly you have a young lady with a reproductive age group. So in those, cyclophosphamide may be a choice, but which can cause a lot of reproductive side effects. So those things have to be discussed with the patient and those should be kept in account while deciding the treatment. Also, whether patients have extrapulmonary symptoms and whether we can treat all these manifestations with single drug versus whether we need to give different drugs for skin versus ILD. Those are the things based on which we decide our treatment plan. So before I decide the treatment, I would tell you what is the natural history of scleroderma ILD, because that is very important to understand that when we decide to treat it. So just focus on these 2 points. So if you see, almost 2/3 of patients with scleroderma ILD would either improve with some treatment or would remain stable. So a significant proportion of patients may not worsen with time. So decision to treat in every ILD is based upon the progression and the extent of involvement rather than just the presence of ILD. So we have to look at what are the risk factors for progression of ILD in scleroderma. So male patients, UIP pattern, smoking, South Asian, it's in older age or diffuse disease. These are the risk factors where we need to decide that yes, this patient, even with a limited disease, may require treatment for the same. So how do we stage the disease into limited ILD or extensive ILD? So this is based upon the HRCT. So if you have a less than 20% involvement or HRCT, it is called as limited disease. If you have more than 20% involvement, this is called as extensive disease. If it is kind of non-quantifiable or not clear that how much of the lung is involved, then comes the role of spirometry. If you have impaired spirometry in the form of FVC less than 70%, then it is extensive disease. If it is more than 70%, it is limited disease. And this classification was published long back, but this is still in use to taking major treatment decisions in scleroderma. So when do we decide to treat? When disease is extensive, patients will usually need treatment. However, even patients with extensive disease but a fibrotic disease may still be observed. These are from the Australian guidelines. And limited disease or subclinical disease which is stable may actually be observed and treated based upon the progression of disease. So that means once you diagnose, you need to follow them up to take a treatment decision. So what are the drugs which are used for treatment of this disease? The first thing is that steroids do not form a major component of scleroderma ILD. However, low dose steroids, that means less than 20 milligram per day of prednisolone equivalent, only may be used on case-to-case basis. So what are the drugs which we have? So I have just enlisted the drugs and the trials which have used them. One is the cyclophosphamide, mycophenolate mofetil, rituximab, tocilizumab, antifibrotics, that is nintedanib and pirfenidone, and the stem cell transplant. These are the therapeutic options which we have for patients with scleroderma ILD. Now I'll talk about some of these trials, not all, but some of them. So the first trial, because these are the key important trials for deciding treatment. This was the SLS1 or the scleroderma lung study 1, which was published long back in 2006. It was a multi-center RCT and it compared oral cyclophosphamide versus placebo with a 12 months follow-up. And this study actually showed that cyclophosphamide was associated with improvement, and this study established the cyclophosphamide as standard of care in scleroderma ILD. The next study I'm going to discuss is the SLS2 study, which was the scleroderma lung study 2. So this study was an RCT which was published in 2016. It compared mycophenolate mofetil in a dose of 3 gram per day versus oral cyclophosphamide for 12 months. And this found that mycophenolate was actually non-inferior to cyclophosphamide with a better safety profile. And this study established the role of mycophenolate in the treatment of scleroderma. So these are the two drugs. Now this is the trial which was recently published, recycle trial, very talked about trial in rheumatology. This is on rituximab. This trial was a multi-center RCT. It included multiple diseases and 40% patients were scleroderma. And this compared rituximab versus cyclophosphamide. And the rate of change of FVC was 99 ml in cyclophosphamide and 97 ml in rituximab with a better safety profile in rituximab. So this study established that rituximab is non-inferior to cyclophosphamide with a better safety profile. Now we have studies on tocilizumab focus trial and we have studies on antifibrotics. So I'll be talking about antifibrotics a bit. So Census trial was on nintedanib 150 milligram twice daily. This is a drug which most pulmonologists use more often. So this trial actually demonstrated that use of nintedanib in scleroderma ILD was associated with reduction in the rate of loss of FVC. Okay, so this led to FDA approval of nintedanib for treatment of scleroderma. Next trial is SLS3 trial, scleroderma lung study 3, which was on pirfenidone. This is only available as abstract partial results, but this showed that pirfenidone did not reduce the decline in FVC. And as of now, FDA has approved only tocilizumab and nintedanib for treatment of scleroderma ILD. All others are not FDA approved, but they are standard of care. So how do we monitor these patients? For initial 2 years, if we have mild disease, we can do PFT every 6 months. But if we have a moderate to severe disease, we need to be more frequent from 3 to 6 months. HRCT chest baseline is required, but for progression, it is only when you have a worsening or an acute deterioration, and echocardiography as discussed by Dr. Nimish for PAH. So this is a kind of a summary and what I want to tell you. Once you have a patient with scleroderma, you look at as FVC and CT. If there is no ILD, then you monitor them for development of ILD. If you have a limited disease with risk factors, then only you treat. If you have extensive disease, you treat. This is from the ACR guidelines recent, that mycophenolate, tocilizumab and rituximab are the first line options for treatment of scleroderma. This was one study which I did under Dr. Uma Kumar's guidance long back. We included 20 patients on scleroderma, not on immunosuppressive therapy, and we did a bronchoscopy and lung function at 6 months, and we found that cyclophosphamide was associated with improvement in skin scores and 6-minute walk distance as well as the DLCO. We also looked at the BAL cytokines, and we found that BAL cytokines in the form of interleukin 7 actually reduced, but interleukin 6 was continued to be high. This was in 2012, and after that actually anti-IL-6 therapy has already been approved for treatment of scleroderma ILD. So these are the additional treatments: pulmonary rehabilitation, oxygen as needed, vaccination, comorbidity management, and nutritional management of these patients. So this is my last slide. What are the challenges which we face as clinicians for management of scleroderma ILD? Because we do not have the precise mechanism of disease. So treatment is based upon a lot of kind of thinkings and pathways which have been established. Many a times disease is missed or misdiagnosed when you do not have systemic manifestations and you only have lung dominant presentation. There are protocols which are mostly consensus based, but the problem is that there is a high inter as well as intra-center variability of protocols of screening as well as management of these patients. And because of the variable clinical course of the disease, who should be treated, when it should be treated, and with what agent to be treated is highly individualized, and a lot of personal opinions go into this. And when we are talking to a patient for this disease treatment, we have to talk to the patient regarding realistic goals, whether we are looking at the stabilization of the disease or the improvement of this ILD. So that's all. Thank you. Now I would invite Dr. Rudra to go.
Thank you, sir. So we have already got 2 excellent reviews on how to suspect ILD, how to evaluate ILD, and how to manage it. So let's see how we did over our 3 decades of experience. So in our ILD cohort, we have 320 patients, and we used mostly these 4 drugs in 265 different evaluable treatment, almost equally distributed. So, cyclophosphamide as an induction agent, or mycophenolate as an induction agent, or rituximab. Azathioprine, mycophenolate, and rituximab are our maintenance agents. So let's see. So this is a cartoon that depicts when in the timeline we are using which drug. We have 2 peaks, one approximately over 2008, and this red and blue lines show cyclophosphamide groups. And later on, over the last decade, we have shifted over to mycophenolate and rituximab as our induction agents, with a slighter peak of persisting cyclophosphamide and MMF as another second, possibly a third common choice. So how did they do? So this is a short-term outcome. So if you remember SLS1, the legacy effect of whatever induction agent we are using persists for at least 18 months to up to 24 months. Keeping that in mind, we will analyze our induction agent effects for the first 2 years. So if you look at the percentage predicted FVCs, from baseline to 12 months, there is an improvement. From 12 months to 24 months, it is stabilized over time. This is the result of a repeated measure GL, generalized linear modeling, adjusted for baseline. So all the baseline FVCs have been coagulated to a single part, and we are trying to see how they are doing. So the clear increasing slope is with the rituximab, and the flattest line is the maintenance mycophenolate. And the difference between these two, so a clear increase in rituximab and a somewhat increasing cycloplast MMF arm has a significantly different slope over time compared to the cyclo and ajar and
sole mycophenolate. This we have to take with a pinch of salt because mycophenolate dosage have not been uniform. Some patients were treated with 1.5 mycophenolate, some are treated with 3 to 3.5 mycophenolate. So that sub-analysis, that sensitivity analysis has to be taken. To look for the baseline effect, we did a GE, general estimated equation, that looks for repeated measure changes over time for linear data. And basically, we are now looking for slope, how fast the increase or decrease is occurring. So you can see this is the slope of the rituximab, and this is the slope of the cycloplas mycophenolate. The baselines are so different. The patients who are given cyclophosphamide plus mycophenolate are the worst patients, and they have the same slope of the rituximab group over the next 2 years. And these were the slopes of this is the slope of mycophenolate and this is the slope of cycloplas. So for the first 2 years, cyclophosphamide is actually a very good choice. It increases FVC even in those who have the lowest possible FVC to start. And we cannot discount for the effect of baseline. Now let's see what happens over 10 years. So over 10 years, the legacy of cyclophosphamide is not there. So the effect of the maintenance agent comes into fold. So our maintenance agents are rituximab, mycophenolate, possibly the commonest, most traditional, most used adapter. But with adaptation, the probability of having an FVC decline over 10% over 1 year is the highest. And with rituximab, this probability is the lowest. We did a survival curve analysis on this, and so this is the result of a Cox regression analysis, and we can clearly see that we have good effect of baseline FVC even after adjusting for that. The odds of not having an FVC decline by more than 10% is highest with rituximab, followed by mycophenolate, compared to cycloplas aja as my comparator. So obviously, for a very long, prolonged period of time, for progressive ILD patients, especially those who have perhaps previously failed the treatment, mycophenolate or Ritux as maintenance agent possibly trumps other drugs. So we published a meta-analysis with generous help from and guidance from Dr. Animesh Rai back in 2021 on rituximab in the treatment of sclerosis ILD, and this was cited recently as one of the guiding evidences for putting rituximab as grade 1A for treatment of sclerosis ILD, which was never done before. At least for the past 10 years, the guidelines talked about tocilizumab, mycophenolate, nintedanib, and whatnot. Rituximab was consistently disregarded. For the first day of 2023, after the application of the cycle and after the application of the rituximab come to the field. But we have a long way to go. HSCT, autologous stem cell transplant, is here to stay. I don't know if our hematology colleagues are here. We would love to collaborate with them to start this. This has the promise of being a game changer. And then we have DAISY, anifrolumab. Interferon blocking has shown to be excellent in cutaneous manifestation of lupus. DAISY is the ongoing trial. AIIMS Rheumatology is the center from India in DAISY, and we are yet to see that. Lastly, and possibly not least, is the new kid in the block, that is CAR T-cell, which holds promise in multiple autoimmunities. Let's see, possibly it holds promise in scleroderma as well. That in our mind, let us look at other manifestations, non-ILD manifestations of scleroderma from Dr.
Thank you, Dr. Rudra, and good evening to everyone. So, after looking at the skin and the lung, I'll be speaking about three non-pulmonary manifestations. So, the first one of them is the PA, which is the most morbidity-causing manifestation after ILD. So, this was a small study that was done long back, but it was done from the department, and to look at the prevalence of pulmonary artery hypertension scleroderma, as well as what are the predictors for development of it. So if you can see that this study was done on 100 patients, and these are the baseline clinical features. And among them, I would like to highlight the two most important ones, which are the dyspnea and PH. which basically is because of the ILD and pH itself. And you can see the prevalence is higher as compared to the Western population in our patients. And if you look at the prevalence of pH amongst our patient, it is somewhere between 20 to 30%. However, if the age of onset is later, the prevalence also increases amongst the patients with scleroderma. Now, what are the predictors? That was the second part of the study. And if you look at the data, the multivariate analysis, looking at that time, the possible causes, the possible predictors done with the interstitial, the presence of interstitial lung disease, presence of telangiectasia, duration of disease, whether it is less than or more than 6 years, and acro-osteolysis did not give us any predictors. This was an older study, almost. And the cutaneous vascular manifestations, which is basically Raynaud's phenomenon. So the study drug was given for 3 months in 17 patients, and evaluation was done by 6-minute walk test, dyspnea class, the WHO class, the severity of Raynaud's phenomenon, how it improved the person, and the echo to look at the pulmonary artery pressure. The drug was administered 3 times a day, and these are the baseline characteristics for 16 patients because one patient did not complete the 3 months follow-up. Now we look at the effect in all the 3 factors that we wanted to see. So the first one is about the 6-minute walk distance, and you can see all the 16 patients, pre-intervention 6-minute walk distance shown by a blue line improved by after 3 months. Similarly, we look at the WHO class, which also improved in almost all the patients, which is shown by again blue line improvement to the purple line. And then we have the severity class, WHO dyspnea severity class also showing improvement. The other parameter was the pulmonary artery hypertension. The mean pulmonary artery pressure decreased from 44 to 27 millimeters of mercury, and 6-minute walk distance increased by almost 30. Now, what do we have in a long-term follow-up? Now, we have almost 350 patients. So, in our data, it shows that the presence of pH is in almost 1/5 of our patients, and median time to development of pH is 1 year after diagnosis. And the incidence is around 31.6 per 1,000 person year. Now, what are the predictors? At that time, we did not find any predictors, but if we look at the long-term data, we have looked at the clinical as well as the serological parameters, the factors which could predict. And if we look at, first of all, the serological factors, which could be the antibodies, RNA polymerase 3 and centromeric antibodies, both of them have an odds ratio of almost 4 to 5 for development of pulmonary artery hypertension. And in the clinical features, age at presentation, it is again showing a very slightly increased odds ratio. But in clinical features, if we see, presence of ILD is significantly associated, which is expected with development of pulmonary artery hypertension. Here, there is a difference between NSAIP pattern and UIP. The patients who have UIP pattern are almost 3 times more risk than the patients with NSAIP for development of pulmonary artery hypertension. In the GI involvement, we had another small study done on 35 patients some time back. And these patients were examined, clinically examined, done with the small 3 set of investigations, barium swallow, hydrogen breath test, and upper GI endoscopy. And patients who had reported small bowel symptoms went through barium meal follow through and D-xylose test, and large bowel symptoms patients had colonoscopy and barium enema. And if we see in this cohort, median age of onset was 25 years, and we had almost 3 times the patients with limited involvement. Breath test was positive in 35.3%, almost 1/3 patients have bacterial overgrowth. Dysphagia was the commonest symptom, and it was higher in patients with limited cutaneous involvement. GI involvement overall was seen in almost 80% patients, and upper GI involvement was almost 3 times more common than the, it was present in almost 3/4 of the patients. And however, again in this study, if we try to correlate the GI involvement with respect to age of onset, duration of disease, the type of disease, we did not find any correlation. Now, the last manifestation that I'm going to speak about is myositis. In our cohort, it is present in 25 patients, that is almost 8%. And if we look at the predictors as compared to patients who have scleroderma without sign scleroderma, basically, who do not have skin involvement, the predictors, the odds ratios for development of myositis is higher in patients who have Jovan antibody or PMSCL, which reaches to almost 3 to 4. That's all from my side. I would like to hand over to Dr. Narendra Bagri to speak about pediatric aspects. Thank you.
Thank you, Dr. Ranjan, Dr. Rodhar, and Department of Rheumatology for inviting me here. So this slide is basically to haze out the common misunderstanding that is scleroderma and the sclerosis are one and the same thing. So, and my dermatology colleagues would agree that scleroderma is typically a disease which is limited to skin only, whereas today what we are talking about is systemic sclerosis, which is altogether a different ball game, which involves the internal organ involvement. So for that, the congenital scleroderma, we have reported a child who was presented as early as 2 days of life with this skin involvement in the over the face. And this again, I don't want to undermine the importance of congenital scleroderma or the scleroderma by saying that it is only involving skin, but it is again equally important because of the severe cosmetic disfigurement it causes. Okay, why is there any difference between pediatric and adult systemic sclerosis? That's the topic of today's discussion. So the answer is yes. And if we look into the large database, the common differences between juvenile and the adult onset systemic sclerosis is, as we can see, that the major difference is the diffuse cutaneous involvement. Diffuse cutaneous pattern is more common in juvenile patients as compared to adults. And in contrast to the adults, the end organ involvement, such as pulmonary arterial hypertension and the interstitial lung disease, are less common in pediatric patients as compared to adults. And accordingly, we can see that the treatment differences, if we look, although as has been discussed so far, broadly the treatment principles remain same, but as we can see that major manifestations of pediatric or the juvenile systemic sclerosis is articular or myositis, and therefore probably the use of steroids and methotrexate are more common in pediatric patients as compared to the adult ones. So coming to our cohort over the last 15 years or so, we have 42 patients, and the majority of them are around 19 are overlap patients, and the mean age at diagnosis is around 12 years, which is equivalent to the global cohort. And majority of them are females. So this is one of our retrospective data series which we have published, and this is 32 children with 21 girls, and we can see that again the diffuse systemic sclerosis is the most common, which is present in our cohort, and around 1/3 of the patients had an overlap systemic sclerosis. And the mean age again of presentation is around 12 years of age. And but the important point is what Dr. Rudra was highlighting at the beginning is the delay in diagnosis. And here again we can see the delay in diagnosis is around 3 years or so. So if you look at again the common clinical features are more of the Raynaud's phenomena and the vasculitic features and the arthritis and the muscular and the myositis kind of. Although only 3 patients in this cohort had ILD, but probably that was because of the retrospective nature of the study, and probably we were not proactively screening these kids for ILD, and they did reasonably. I mean, 50% of the patients did well with methotrexate and bit of steroid and the treatment we used, but it is a bit disappointing to see that the overall outcome is not as great as compared to the Western world, and this probably is because of maybe they are using more aggressive screening strategies. And having learned from this, probably over the time, this is the broad treatment principles for the management of juvenile systemic sclerosis. The broad principles remain the same. If the disease does not involve internal organ, and the internal organ again here remains the same as in adults, that's the ILD or pulmonary arterial hypertension. If that's the case, probably the drug would be MMF or cyclophosphamide, or of late we are more towards rituximab or tocilizumab in some series, and then methotrexate. Low dose of steroids are indicated where the predominant manifestations are vasculitis, dermatomyositis, or maybe Raynaud's phenomena or articular manifestations are there. One of the debilitating manifestations of systemic sclerosis as the disease begins with the Raynaud's phenomena, and as the disease advances, the Raynaud's phenomena is very debilitating and lots of vasculitic ulcers are there. So this is one, I mean, sympathetic block is probably a short-term benefit for most of these patients, when while giving this systemic blockade, probably there might be some benefit at least in the beginning, and we have cohort of around 68 sympathectomy blocks which have shown a reasonable improvement in at least short-term follow-up. So as we've understood that there is a huge difference between the pediatric and the adult cohort, and this is 2 days after today, we are going to present this data where our center is a part of this consortium, international consortium on pediatric scleroderma. And what we are trying to propose is the developing classification criteria for juvenile systemic sclerosis. And the key findings from this international cohort as of now is that there are certain features which are more common in pediatrics, such as vasculopathy, and probably the overlap associated autoantibodies are more common in pediatric cohort, but whereas the renal crisis, tendon friction rub, and the other host of autoantibodies are less common in pediatric cohort as compared to the adult one. And this is probably, if we look into, I told that probably there are only 3 patients which we published as having ILD, but that probably was because of the fact that we were not aggressively screening them. And when we screened these children, 11 out of 19 children, that is around 60% of them, had some features of ILD on CT scan. And again, the most common one here is NSIP pattern. This is not specific to pediatric or juvenile systemic sclerosis, or for that matter, in a broader perspective, not to systemic sclerosis, but this is what my colleague Rudra was mentioning, that this is something which is probably sitting next to the door, but yet has to enter the door. And this is CAR T cell therapy, which is making a lot of noise in rheumatology world for disorders, particularly like systemic sclerosis, where we cannot actually offer a word cure. And I think everybody here would agree that we cannot offer the word cure for this. Again, while using this, whether we'll be able to offer that word or not, I'm not sure. But yes, there is evolving data, including juvenile systemic sclerosis, where there is an improvement with use of CAR T cell therapy over the time. And this is nothing but they just probably reboot immune system, deep diving into the CD19 story. And there is an improvement in the outcome in terms of ILD or the skin manifestations with use of CAR T cell therapy. So this is all about pediatric juvenile systemic sclerosis. Thank you so much.
So this will come to the end of our session here. So what happened to our patient? The patient started a journey with Raynaud's. She had a delay in diagnosis, which we could reduce over the next 2 decades to maybe 1 year. But finally, she had a Raynaud, she had a digital ulcer, she maybe had a gangrene even. She maybe, despite having all these excellent drugs, she possibly has developed one or other internal organ. So what we can offer today? We can offer a mollification of our ailments. Can we really cure them? We are significantly lacking in that department. And with this, with the rays of great hope that Dr. Madhuri showed us, the next kids were lying just outside our doors, I must thank all our colleagues and all the departments that we have mentioned over here, all the departments that I have not mentioned over here, and above all our patients. Thank you. May I open the floor? Any and all questions are welcome.
We recognize that it has a greater magnification and that we can store it in the laptop. So we use our the microscope. So that's very, very portable. Exactly show the so with a slightly lower magnification, we can attach it to a mobile phone, and therefore we can see all these images also. So you don't need to carry a laptop everywhere. You can very, very portable and easy to use. Number 2, we also see we should recognize that patients of generalized morphine prefer to use morphine rather than steroid. Recognize the same umbrella for non-systemic. also recognition of pseudoscleroderma is important because we see that from non-dermatology specialists, these patients are claiming that systemic sclerosis, despite being of dermatology, and many pseudoscleroderma conditions that in certain situations need to be before. Most of the systemic sclerosis, especially early onset of the probably they have only skin. Because these treat manage issues of systemic sclerosis also quite a bit. And it's a large proportion of inpatients. So we often see that there is a significant discordance on PFP. Made a passing remark on the lack of utility of it's always there in the line. The patients are clinically asymptomatic, HRCPs are fairly normal, but the efficacy is significantly lower. And we continue to see that we're not distinct. HRCPs are also kind of less than 20%. So, we see that quite often. Each one of these.
I personally say mostly due to skin disease. The lungs are not expanding that much. And most of the early changes of the existing often lost have both the components of lung and skin. Both lung and skin tend to improve over the first 2 or 3 years, and that compounds existing. People in the upper part have like this that produce of other quality of a spine because many times patients get spirometry sometimes also have people left there might be some variability from machine to machine. So in your IIT patients always get them the code so that there is no variability. Number two, the chest. What is very true that we see the blood from normal the chest wall in skin as well as the joints. So there is a lot of prevention by lungs to totally on. So that variability
This is a guideline, but 80% reduction in the APC value. Therefore, we expect to see a correct APC, which is important with trafficking, etc., to be able to make that decision because there are confusion with regard to the interpretation.
if it comes after the then has to have involvement 20% involvement then only you take it as this and we need to treat this. Adjustability extent is over the PAP initial stage.
Do mixture and high resolution ultrasound monitoring the utility of over HRCT to reduce the expense?
But it's not for the monitoring. Each unit package can be used for this. Based upon the amount of involvement, you can have the development of
The common for the physiologist. What's the take home message with regard to high resolution? It cannot replace HRCT. And the last question I have is, if you also see patients, then now from their specification, despite being a UIP pattern, being armed with medical treatment, despite their non-progression, and we kind of therefore at that stage stress more on pulmonary rehabilitation or maybe use of antifibrotics. failure, a little bit of immunosuppressant, then just stopping with immunosuppressant. So at what stage do you think we should completely go away from a medical treatment to just pulmonary rehabilitation in a patient, especially for you?
Primary goals are more important.
So, but an duality pattern is unable we start treatment because of the time, even if we have a previous therapies or disease have been stable for very earlier also, then we don't treat these patients. That is one. If we find that disease has been stable for 2 years, then we have to bring out the stop. Two are minimum. But no matter how 2 years should be there, so that we have a complete surety that there is no progression of disease. See, this is very individual decision based upon the amount of disease working of the patient. Antibiotics and immediately do your free and on them after good amount of towards the primary and then you are only
One point of treatment resistance. And secondly, we have shown changes in the earlier patient work with different treatment options. So what are disadvantages like the diagnosis score? Will it change over a period of time with treatment or they remain same? There are any chances of reversing back to normal?
Endpoint is something we want to you are even my patient when I saw my general saw that we have initiated next year, for 5 years, now possibly what happened disease process is stable and we have achieved the stability of 5 years, then now paper down to zero. But after taking down 5 years, this is not going to come back. I said, yes, for last for doing you, but what is actually normal is a very difficult operation. Initial time of the and not my part. Not my part. The primary part is very hard. So there is some data to suggest that there is a very useful
The question is that the pulmonary medicine being very often we are not when we study the issues to work so in that should be followed, should be managed to should they continue
regarding steroids, we tend to give steroids in early stages of the disease. When we start the phytopharmacology, 7.5 milligrams of prednisone, and then we stop. This is first practice which we follow. Second is patients have significant joint pain or joint symptoms. Many times we add the dose of steroids, but other than that, we most of our patients are on microphenolate or equivalent. Steroids.
the second question was
Yes. Points are IIMS process mostly monthly or median low of 7 5 dose for 6 followed by For cyclophosphamide, monthly or 6 months.
So we can still consider the appropriate
Data comes from our work, which is pre-2008. So there we had been using cyclophosphamide even for maintenance. We monthly versus giving for 18 months to 2 years as we so it was good. And we did study also with Dr. Ashu Balla that in 100 patients. And we found that patients who we detected IAD early, very early, it is completely disappeared. Had we not documented it, other person will not believe it. So this is a good drug, definitely. Microbial we are using more. Cyclophosphamide, the more we tell them, it can cause a serious infection and coronary toxicity. Patient says no, no cyclophosphamide. Hospital that point of time we did not have many options available. That's the only reason for
the other one is
To 16 doctors for non-CTD it is a good test because it is a disease which is limited to lung. For CTD the problem is symptomatic disease. So patient joint disease may worsen, patient skin disease may worsen, patient muscle disease may worsen, and you may think their lung is worsening. So that's why 16 doctors follow up CTD identity. It was good.
okay.
Basic difference between the 6-day doctors and their RMP is 6-day doctors employs some maximal. So we tell the patient to walk fast, or not, it's not the best capacity. But for unfunctional RMP, it's always X low that is being counted. So that's also a basic difference between KP, RMP and 6-day doctors. So oftentimes we see in Serena, safety and data. The availability of data sets makes the utility of not that important. We continue, so we continue doing it. We use silent system. When you're oscillating, so your PhD will go to much higher than that. Higher than that. Not just smooth and after maintaining then we say that it's now
So, thank you all. I'm sure the message is very clear. We need to put them on medicines depending on the way it's individualized patient use and all. Could be hurry to abruptly stop that treatment when you feel that patient is we only say 18 months to 2 years, but we do wait for a longer period of time. Steroids, so we don't use so much. Like I don't give steroids at all if they go. But sometimes immediately giving the lesion so that is some patients are doing this well. Patient has other medication for steroids and surely we don't get scleroderma and in our cohort, maybe 2,000, 3,000 see only 3-4 patients. Maybe patients are going at another department that might not be so common. And as you said, that means our patients have potential. Thank you so much for coming in.